always a little rare to listen from you so many things, but anyhow. What is true is that I have been involved in the issues that we deal this morning, and it's a real pleasure to be here participating in the Pre-Congress. This will be now starting the first roundtable on the Congress. So we will make different roundtables. The first one is related to the public involvement in the peer review process of publication. Second is on the role on preclinical and clinical research, especially for OA patients in these COVID times. And the third is the involvement in the regulatory process for patients. In the first roundtable, we have three great speakers. I will present each one of them one after the other because some are here. Ciaran is here, but two others are online and far away. They are in Australia. So good morning here, good afternoon, Australia. Ciaran, the first speaker, is senior editor of Biomed Central since March 2019, especially working in BMC musculoskeletal disorders or rheumatology, so he's an expert on this field. BMC, or Biomedical Central, stands for Open Robust Science, and is one of the very first journals with open access, and most important nowadays, launched in early 2000, I think. So thank you, Ciaran, for being here, especially being from UK now with some logistical problems. Thank you to come to be with us, and the floor is yours for 10 minutes. We will make the questions and answers Q&A at the end of the three interventions. So first 10 minutes, 10 minutes, 10 minutes, and then questions for all. I think it's more practical. And after 10 minutes, I will sign somehow.
Okay, good morning, everyone. It's my absolute pleasure to be speaking to you this morning, whether online or in Congress, and thank you for the invite and presentation. So my name's Ciaran Fitzpatrick. I'm a senior editor at Biomed Central, and I edit the following journals, which include BMC Musculoskeletal Disorders, the largest OA journal, open access in its relevant fields. And BMC were part of the Springer Nature family, which includes the following brands. And I spoke last year about open access publishing and made some recommendations for the future PPI. And what I wanted, just a reminder on what is OA publishing. So it's free to read and reuse for the authors. And we were the first. So we've always seen ourselves as pioneers of progressive publishing initiatives. And look, now you have lots and lots of, as you would say, competitors. One of the great things about OA publishing is that you can read for free without paying subscriptions or paywalls all the evidence and research related to your illness. I have no conflicts of interest to declare, and I do have good relationships with some patient organizations, of which I'm glad to be a partner. And I'm not going to read this quote as I do have limited time, but I did make the point in 2019 blog post about the future and the need of PPI. So that was my road to Damascus moment where I would say my eyes were turned on to PPI and its potential. So I spoke here in 2020, exactly 1 year ago, or online. And I sort of made a wish list or recommendations for us as publishers, both BMC, Springer Nature, but just anyone who is listening, I guess. So I broke it into sort of 3 points. So the first one could have been for publishers to have a diversity, equity, and inclusion program, which would include inclusive language guidance. For authors and patients in the public reading research, I also recommended having plain language summaries, having patients or the interested public on editorial boards as peer reviewers, as well as having some editorial policies focused on getting the best for PPI. And for authors, which I think, you know, for me, for working in publishing, we want them to submit and publish to have them learning as they do it. So those could be reporting checklists, organizations or workflows, editorially checking the PPI quality in a manuscript, and just more general awareness, because education is key. And yeah, I was definitely inspired while compiling this list through the BMC Journal Research Involvement and Engagement with my colleague Jonathan Collin, who also spoke last year and I have no affiliation to Patients Included, who are a really great organization championing PPI across research. So I'm here today sort of having like a self-assessment or examination of what we've done in 1 year, but also just to see how the field has moved forward in 1 year. And I likened open access and PPI to the Millennium Dome, which it was presented in London in 2000. And at that time, open access was seen as unfeasible. And yeah, and look where we are now. So much research is open access, and I would say the majority of people are in favor. And so I liken that to the journey that PPI will navigate. So quickly, I'm just going to go what's going on at BMC Journals to give some context. So I've already mentioned, here's our website, some aims and scope, journal metrics. We're a great lover of special issues for highlighting particular content, which I'll come back to, and learning about submitting or anything. You can see this. I'm happy to send around slides. My email address will be at the end if you ever want to talk about anything. This will be even more relevant in a few minutes, but basically our peer review is transparent, meaning that the reviewer interacts only with the editor and vice versa for the authors and editor. The reviewers and authors do not interact. Reviewer reports are published, but names are only included if the reviewer agrees to that. We're really happy to highlight content and attract really novel and ingenious stuff through special issues. We've recently published on interesting topics such as work, digital health, diagnostic imaging, osteoarthritis, and work. And so what I wanted to spend the second part of my talk, and I hope I didn't glide through that, but I want to just give you an overview of our editorial processes and what was going on, is the wish list or my recommendations, which I guess is the meat of my talk and why I was invited back to talk. And I've just, as a subtitle, called this Making Actions Based on Wishes. So first I'm going to talk about Springer Nature, what we've done. This is publicly available with the link at the bottom. And I've only been involved primarily in one part, but as an organization, we're really working on this. Such as, you know, that we are becoming intentionally inclusive. We now have a diversity policy and code of conduct for procedures such as recruitment. We've open access publication waivers for lower and middle income countries. We have always had this, but these are even more emphasized and communicated and reviewed. We are a signee of the Cross-Publisher joint commitment for action on inclusivity and diversity. And we are bringing in new editorial policies, such as the inclusive name change policy for transgender authors, and inclusive language guidance for authors. So this is included in all public-facing websites, also reviewer invitation letters to ensure that inclusive language is used. And if I can spend 30 seconds on this, it's guidance for both authors and referees, because members of communities with common identifiers may have preferences in the terms of how they are described, and wrong language can be highly offensive. So Springer Nature is guiding authors to be mindful of the way the community prefers to be described. So there are two sets of language you typically occur: people and identity first. So for example, a person with arthritis prefers to be defined as a person and not by their condition. So we'll be giving guidance, outward-facing links, and a couple of examples. And we also have early careers researcher, program where we're training people from developing countries, minorities, to learn how to peer review an academic paper with a mentor. So we're also, at the start of the year, we ran a consultation period with editorial board members of BMC Rheumatology. How could we highlight and champion PPI with setting certain policies or rules? And I decided to go forward with a call for papers highlighting PPI research in RMDs. We have a host of really great guest editors, some really great academics who've been involved for PPI for a long time, but also two patient advocates, Angie and Wendy, who are super great. I'm not going to go through this, but the things that I mentioned, like a lay summary, patient reviewers, GRIP 2 checklist, and using inclusive language rulings, we specified this in the call for papers. So because with a special issue, you can set certain parameters which you would otherwise have to do by introducing certain editorial policies. Those things take time, whereas a special issue, you can set the parameters of engagement. And we commission a whole host of patient-only and patient co-production reviews, commentaries, editorials, because research should be carried out alongside patients of the public, or patients and the public, and not for them. I'll send my slides around, but just a few different topics, such as a how-to toolkit for early career research to include PPI in their research, or how to advertise on social media to get people, the public and patients, involved in your studies. And one thing that I'm super excited, and we had a video kickoff call, we do have patient reviewers on the BMC Rheumatology special issue submissions. It's been really great, actually, super inspiring to get to know them, and sort of makes you realize why you're involved, or why I'm involved in academic publishing. And yeah, the infographic to the left actually is just how research involvement and engagement, the BMC journal does their peer review with a co-handling editor of academic and patient reviewer, with patient and academic reviewers. We're going to have patient and academic reviewers with one handling editor, either a patient or an academic. So yeah, we're super excited. I think we have about 15 people on board, and it's been great to get to know them. And we have guidance from research involvement and engagement to guide them through the process. And to finish, I think it's super important that we're engaging our community, both externally and internally. So we've had a focus issue already across the 64 BMC series journals about highlighting all the great PPI-related content across our journals from all sorts of fields, from cardiovascular to musculoskeletal to just metallurgical studies. As I described initially, to set the guidelines or the scope of the special issue, we use private consultation rooms with the editorial board of BMC Rheumatology. A lot of them have relationships with PPI, and we were basically feeding them questions, and they were responding saying, hey, no, you're doing this wrong, or you need to do this based on our experiences. Also in our search for guest editors, patient reviewers, commissioning content, they were invaluable source, as I'm only one person and there's a diverse viewpoints and experiences out there. So this is my last slide, and it's just sort of a self-assessment like you do with your tax in the UK. So green, I think, is good in that we have introduced some inclusive language guidance. Points 2 to 5, I think we've accomplished with the special issue, so we had to think outside of the box for that, because changing editorial policies at the Springer Nature family, it would be for all journals, which is just something not feasible right now. And again, for points 6 to 8, it's about, demonstrating that a pilot, like a special issue or patient reviewer pilot, can work, is feasible. The community wants that and is open to that, and then delivering it on success, and then you can perhaps roll it out to a wider group of journals. That's me. Thank you very much. And yeah, any questions I'd gladly receive.
Thanks, Ciaran. It has been incredible. 10 minutes. You look British, although you are not. And now, with the technology, we are moving to the other hemisphere, to the southern hemisphere. We go to Australia, and we have the pleasure to introduce you to Mabel Chu. I'm sorry if I don't pronounce the surname correctly, Mabel. Mabel has been involved in different journals, classical journals, old-fashioned journals, like now in Lancet, before at BMJ, and in the Medical Journal of Australia. And you have been interested in different topics, among them on chronic pain. That's an important issue for our Congress here. Thank you, Mabel. The floor is yours for around 10 minutes, please. And good afternoon.
Hello, thank you so much for having me. It's very kind and a great honor to be asked to be part of the OAFI Pre-Congress. I'm here at the invitation of OAFI to talk about Lancet Commissions and patient and public involvement. Can everyone hear me, by the way? Is it?
Yes, yes.
Yeah? Okay, good. Okay. Right, so as has been said, I'm senior editor at the Lancet. I'm also a practicing general practitioner or family physician here in Sydney, Australia. And I find that one of the benefits of having the privilege of being both a medical editor and a physician are that each role also informs and enhances the other. So that's the perspective I hope to bring today as well. Just a little bit about the Lancet, if I may. It is not just one journal, but a whole family of journals, and it now includes over 18 titles, including one of the more recent additions to the family, the Lancet Rheumatology, which I think you should be able to see down here. Having worked at different journals now, several great different journals, I've been able to appreciate the different strengths of each. And one of the Lancet's strengths is its distinctive decision-making process, whereby papers are discussed at meetings attended by the specialty journal editors as well as the general medical journal editors. And I think that brings two two advantages among many. One is that we are able to draw on the breadth and depth of expertise and perspective in the field, and it helps us to come to the best decision possible for a paper. The other is that it uniquely includes the cascade system, whereby if a paper is not suitable for that journal it's been submitted to, we can then try and work out if it might have a more suitable home elsewhere in the family. And that's been a tremendous thing, I think. I should also add that the Lancet now includes its regional health journals, which correspond to WHO regions. And the ones that we have already rolled out are the Lancet Regional Health in Western Pacific, Lancet Regional Health in Europe, and the Lancet Regional Health Americas. They aim to advocate for healthcare quality and access in different regions of the world, and to foster good clinical practice and health policy to improve regional health outcomes. They're really a very welcome addition to the family. So what is a Lancet Commission? It's basically a scientific review and inquiry, a response to an urgent, perhaps neglected or understudied health predicament. It's science-led, so it's going to be evidence-based. It draws on an international collaboration, so it will include commissioners and authors who are from low and middle income countries as well as high income countries. It's multidisciplinary, so it will draw on the benefits of different expertise, including that of people with lived experience, as well as the benefits of other types of diversity such as age, gender, career stage. Lancet Commissions aim for transformational change. So we're aiming to transform lives in society, not just putting together a document that's good to know. So that means that it's going to be focused on policy or political action, as well as change in practice. Lancet Commissions will have a bold message. So this is the Lancet Commission on Dementia, which have the message that acting now on dementia will vastly improve living and dying and transform this, the future of society. Process involves selecting topics and then working with experts who come from, as mentioned, these diverse backgrounds, disciplines, and countries. The recommendations translate research into real-world impacts, and we're going to look at change in policy or change in practice. Our projects usually last about 2 or 3 years, and we're in the middle of cooking one for osteoarthritis, very relevant to the audience here. Lancet Commissions are subject to the same rigorous peer review and decision-making process as our research papers. And that's very important to us. What is peer review? I think the pandemic has thrown around that term quite a lot. I know that before I became a medical editor, I had a very, very hazy, even though I'd been medically trained, I only had a very hazy idea of what peer review actually was. And it was always a bit of a mystery, even though I'd been an academic and I published, and it was all a bit of a black box. And I think I would have appreciated seeing this video, which helps to demystify journal processes a little bit. So I hope you'll forgive me if I just get this going, and hopefully you'll be able to view and hear it too. I always get a bit nervous about videos.
Mabel, there's no audio.
I'm sorry, can you not hear it? No? Okay. Well, yes, right. I'm right to be nervous about videos. I'm sorry about that. And I had hoped to be able to do the captions as well in case the sound didn't work, but that's not working for us, I don't think. Anyway, look, I'll carry on. So peer review, the formal definition of peer review, I guess, is that it's an external evaluation process in which we ask independent experts to assess the article and help us come to a decision on the paper. Reviewers are asked how the commission fits with previous research, previous work, and whether recommendations are supported by evidence, whether they're useful, whether they're feasible. And reviewers' comments are then fed back to commission authors as they revise the paper before publication. Patient and public involvement can take a number of forms with commissions. As major disseminators of knowledge, journals are aware that we can no longer afford not to include the expertise of patients, whose health we help to improve. And PPI is gradually, increasingly becoming embedded in our daily processes and our structures even. So for Lancet Commissions, patients may become involved as commissioners and authors. So they will help us determine priorities that matter and help us formulate recommendations to ensure that the commission is going to be relevant and useful to the people we're trying to reach. Commissions will use panelists of service users who can feed back to us on drafts before something's been submitted to a journal for publication. And we also, once a commission's been submitted, we'll also seek the opinion of peer reviewers who are patients or carers or consumer advocates. And again, this is with a view to making sure that the commission is as relevant as possible to our audience. We may also ask for people with lived experience to write comments or articles, editorials that are going to be linked to the commission itself. And then this will be published side by side with the commission. And other examples of how patient and public have been involved in Lancet Commissions, for instance, are that the Lancet Child and Adolescent Health Journal has recruited youth and I forget the formal name for it, but a youth advisory board comprising people from the ages of 16 to 24 with lived experience of illness or who may have a passion for health advocacy from across the globe to advise on content and important issues. The Lancet Psychiatry has a formal service user panel from which they draw peer reviews on their papers, and not only for commissions, but research papers, opinion pieces, etc. And they do also provide some training for peer reviews. These are some of the questions we'll be putting to our peer reviewers who are patients or families of patients or consumer advocates. The first might be, what are the key priorities for patients, their families, and carers? What are the key challenges faced by patients and carers? And even more importantly, I think, is how can we overcome these challenges? So again, this is with the aim of making sure that things are as relevant and useful as possible. And then finally, how can the commission be strengthened to increase understanding and action by the various stakeholders that are out there, by clinicians, by healthcare organizations, policymakers, even the general public. Here are some examples of commissions published by the Lancet with patient and public involvement. So the Lancet Respiratory Medicine, for instance, published a couple of years ago, commission on the future of cystic fibrosis care, which included patients as co-authors of the commission. It also had a linked comment, which they commissioned from a patient who provided their own perspective on cystic fibrosis care. The Lancet Hematology not only included patients as commissioners, but also people who were part of consumer advocacy groups. The Lancet Child and Adolescent Health had a recent commission on pediatric pain, in which young people with chronic pain and parents of young people with chronic pain were also authors of the commission. We have in the pipeline, as I've mentioned, the Lancet Commission on Osteoarthritis. We have some terrific people on board as commissioners, including several patients and consumer advocates. And we plan to include patients as feedback panelists and reviewers as well as part of the process. The Lancet's shortly going to be publishing its commission on autism, and that has included both commissioners and reviewers who are patients, and also embedded in different aspects of the editorial process and as commissioners, as authors. The Lancet Psychiatry has 2 commissions coming out on intimate partner violence and mental health, and another on youth mental health services. So I hope that's given you a bit of a flavour of what Lancet Commissions are about and how we try and include patient and public involvement. So thank you very much for the opportunity.
Thank you, Mabel. Very interesting, the participation of patients in this type of commissions. I think it will be very fruitful, and that you have one on OA, it's very, very encouraging. Now we then move from Australia. We have so far Professor David Hunter. He's a very well-known rheumatologist, has worked in rheumatology since many years. He has been professor of medicine at the University of Sydney and is one of the leading experts in the world of the osteoarthritis condition. So he's also Richard Doll Professor of Epidemiology and Medicine, so I think I have some links in common with him because I knew very well Sir Richard Doll. So David, the floor is yours for 10 minutes from this beautiful beach where you are.
Thank you so much for the very kind introduction, and it's a great pleasure to be with you this morning. And my humble apologies that I can't be there with you in person in Barcelona, but I would love to be there with Giuseppe and Ali and colleagues from OAFI. It's a wonderful privilege to have an opportunity to speak to you about a topic that's very near and dear to my heart. And it's also wonderful to have had the 2 previous speakers give a wonderful overview of involvement of people with lived experience in publishing, which I'll hopefully emphasize a little bit as we talk about the Lancet Commission on Osteoarthritis. I first, though, want to acknowledge the traditional custodians of our land and pay my respect to elders past, present and emerging. And I'm speaking from the Gadigal lands of the Eora Nation. I do have a couple of disclosures that I need to let you know about that I'm not going to be talking about this evening, where I do some work for a couple of different scientific advisory boards, and most of my support comes from the National Health and Medical Research Council in Australia. As Mabel wonderfully introduced, there have been a wonderful road paved for us with tremendous previous commissions that have come out by the Lancet. These are just some examples of them. And I'm just going to highlight one of these, specifically the Lancet Commission on Dementia. It's obviously draws some close parallels to osteoarthritis, but I think it's really important that we, I guess, learn from the previous experience of these wonderfully powerful commissions that hopefully set a really important precedent for us in the osteoarthritis field. This is one figure that's come from the Lancet Commission on Dementia that I think potentially has some important parallels in osteoarthritis. Specifically, this looks at the life course of a person from early life through to later life, and the impact of various factors and the magnitude of those factors through that life course journey. And so, I think one of the really important elements about the Lancet Commissions is the wonderful use of graphics to portray really complex concepts. And this is one example of that from the Lancet Commission on Dementia. Obviously, our commission is focused on osteoarthritis. And as you well know, this is an incredibly common problem. Affects about 1 in 8 adults. About 500 million people around the world have symptomatic disease and have impact on their daily lives in terms of functional limitations and disability. The impact on the individuals is such that for 2 in every 3 people that have osteoarthritis, the last time that they were pain-free was over a year ago. So it has a tremendous individual burden. And obviously that's something that we're trying to capture, that impact through the purpose of the Lancet Commission and pave a road, hopefully that's transformative and consistent with what Mabel's just outlined to us about ways that we can improve that course. For those of you that might have missed it, this is the comment that came out about the Lancet Commission in the latter part of last year that was authored by Lynn March from the University of Sydney, Mabel Chu, who you've just heard from the Lancet, and myself on behalf of a range of Lancet commissioners that I'll introduce again in a moment, that includes, importantly, people with a lived experience of this disease. Our overarching aim is to provide a commission that gives transformational change with a particular focus on policy and change in practice. The commissioners in large part have been introduced to you by Mabel, but I really just want to reinforce some important concepts here. We have representation from multiple disciplines that represent, the clinical experience that a person with osteoarthritis might be exposed to, from primary care, physiotherapy, orthopedic surgery, rheumatology, and a number of other disciplines as well. Really importantly, because I think this is often forgotten in many other opportunities to publish, we have representation from low and middle income countries. And I think the importance of that is that oftentimes the burden of this disease is felt more by those who have less opportunity to access health services, surgical interventions, medical care, and so on. And that disproportionate effect is something that we hope to address through the Lancet Commission. Consistent with the theme of this evening's session, we have a number of people who have lived experience with this disease, and their voices heard from the point of design through to writing up the Lancet, through to review and appraisal of the work. And as Mabel mentioned, in addition, we're also planning to have people with lived experience review the work as it comes out. And obviously there'll be a strong focus on dissemination and translation, and we'll intimately involve people with lived experience to ensure that that reaches both the target audience, but also uses language that's consistent and appropriate for that audience. These are the Lancet Commissioners. You will know many of the names that are here, but again, just to reinforce those concepts, it's an international group of people representing multiple disciplines, particularly representation from low and middle income countries, and really importantly, people with lived experience of osteoarthritis. We're well into the process of developing this commission, and at present we're basing that around 4 particular themes, including discovery, trends, and people, specifically data, looking at lowering the prevalence of the disease, with a particular focus on prevention, looking at the future of the way healthcare should be delivered for osteoarthritis, and then looking at the economic impact and looking at the way we can use cost effectiveness analysis to transform the way this disease is managed both at an individual but also societal level through policy change. We have a number of cross-cutting themes running through this, including implementation, so looking at the way particularly healthcare is delivered in a number of different contexts, including low and middle income countries, looking at education and training of healthcare professionals who deliver osteoarthritis management, and with a particular focus on how we can influence healthcare policy internationally. Our overarching aim and the intent of the Osteoarthritis Lancet Commission is to move towards a roadmap to a world with healthy joints, so moving beyond that osteoarthritis experience. For those themes that I just spoke about, we've divided our group up into 4 working groups to try to help to embrace some of those themes in a much more focused and targeted way. There are 4 working groups. The first is focused, as mentioned, on burden, impact, and pathogenesis, so really looking at the enormity of the issue and the number of cases. The second working group looking at risk factors and prevention. The third on framework for how health systems respond. And the fourth looking at cost effectiveness of interventions and programs and solutions for disability for current cases. Not inconsistent with what we saw with the Lancet Commission on Dementia, one of the graphics that we may well feature, and it, this is just a draft, but it might include looking at some of that life course journey from early life through to later life and the impact of various risk factors that play a role in the onset and development of osteoarthritis, and the time that they would have that impact, the magnitude of that impact. Because if we're going to plan to intervene to prevent this disease and do large public health initiatives with policy change, we need to know when that happens and which group particularly to target. Other content that we will be particularly interested in expressing, and again, this is very much in the process of development, is, why are we doing this now? Where do we want to be in 5 and 10 years with this disease? What actions do we need to take as a community, as a society to attain those goals? What are the opportunities and challenges for attaining those? And importantly, what original research could address important priorities? And some really important conversations I'd really like to have with my colleagues at OAFI about that type of original research and how we can better do this as a community. So where are we at? We kicked off in September last year, and we've run through a number of different exercises, including working group consensus, drafting a full draft, looking at review from working group members. We've done some internal peer review, and we're just about to feed this back to the working groups to get their feedback on those drafts. The proposal is to submit this to the Lancet in May next year and launch this in May 2023, hopefully and coincide that with the Osteoarthritis Research Society meeting. In contrast to many of the previous commissions, this has all been done remotely. Obviously, with the impact of COVID, that's been felt quite markedly with limitations on face-to-face meetings and interactions that way. But we've had a wonderfully active and vibrant group of commissioners who've really engaged in that process and helped to nurture this really important work along. So, obviously speaking to this really important audience today, and I'd really like to engage with you and hopefully hear from you about how you could get more involved, and specifically really interested in looking at OAFI and opportunities to assist in research efforts, and particularly once we've got this out there, dissemination and interaction with policymakers and so on, so this can become reality. I'm going to stop speaking there now, but really looking forward to any further interactions with you and opportunities to address any questions that you may have.
Thank you, David. Thank you, Professor Hunter, for your clear exposition and important issue that you mentioned, especially for OAFI. So I think we have now more or less 10 minutes, as we wanted to do, because we have a small delay due to just technical problems. So we have 10 minutes of questions and answers, if possible. So from the floor, there's anybody who can participate in any of the 3 presentations? Yes, Ali, Professor Mobashiri. There is a microphone running.
Thank you, David and Mabel and Ciaran, for a very nice set of presentations. I really couldn't help but notice the similarities between those figures. David, you just showed the draft figure for the OA Lancet Commission and the Dementia Commission by the Lancet. There are lots of overlaps between those. So in terms of public health messaging, there's so much that can be communicated to the policymakers about those early life interventions, particularly when it comes to diet and lifestyle. So I think the impact after the launch in hopefully 2023 could be huge, especially if it's well aligned with other Lancet commissions, and the very clear messaging that you're giving about early life intervention and maintaining healthy diet and lifestyle.
Yeah, I fully agree with his comments. To some other question or remark? So I have some, too many probably, but first is for you, Ciaran. How do you handle with lay members in a situation where, at least in my experience, there's a huge variety of opinions about a certain field? For instance, I wouldn't like to have, for instance, Donald Trump in a commission to decide if hydroxychloroquine is good or not for COVID. So, I mean, the public is very different. You can find somebody in the lay population that is very reluctant to new technology and science. How do you deal with how to choose which is the best option for your editorial?
So yeah, this is a new initiative for us, and as I said, it's a pilot. So of course we're finding out, but to date it's been extremely encouraging. And I should have said during my presentation, we're of course open to new people to get involved. My email address is included at the end, but yeah, I mean, we sort of used through word of mouth, really, and the Call for Papers webpage. We have a link to get in touch via email and a form to fill out with your details, email address, research keywords. Are you interested in, meeting the rest of the reviewers and myself? And actually, we've had, I think, about 15 people who filled in the form, and actually all but one or two are engaged in interest and have experience with this. So the vetting process, there hasn't been much of a vetting process because the level of, let's say, the candidates or the engagement has been so high. And yeah, we had a kickoff meeting via video to introduce the guidelines for reviewing, which that Research Involvement and Engagement Journal already uses. And yeah, we will see how it goes. As I showed in the infographic, so we have one handling editor who's either a patient or an academic, a special issue editor, and a minimum of 2 peer reviewers. So that could be 1 or 2 patient reviewers and 1 or 2 academic reviewers. So no editorial decision is made on one report. It's the consensus views of the full peer review panel. So, yeah.
And my second question is that taking in consideration that the editorial world has changed very much from the classical New England to a journal like yours, the participation of lay members as readers of the journals has shifted very much. You have experience, you have data of how your journals are more open access to the lay population in relation to classical journals. Do you have data on that?
Well, we don't have specific data on who exactly, whether they're a patient or an academic that are viewing our work. What we do know is that open access articles are read more. I think it's depending on what reference, maybe up to 4 times read as much as those behind a paywall. We know citations are maybe 1.5 to 1.6 times more cited. We know they're more talked about on social media, including Twitter. So we don't have that granular data to know that, let's say, more lay people are reading it, but I guess you could extrapolate it that that is the case. If you look at scores which we use, such as Altmetric, which is looking at Twitter, news, blogs, we know that a lot of non-academics are also sharing the work on platforms such as Twitter. So yeah.
And lay press?
Including lay press, yes, but we haven't, let's say, put the data together to show the public use versus the academic use. But it's a good idea and something we can explore, particularly when we're measuring the success and challenges of this special issue.
I have a question for all of the panel. Over the last 2 years, the pre-publication platforms have proliferated massively. So the question is, how do we get patients and patient groups more involved in evaluating papers that are not yet peer-reviewed? So the papers go out to a pre-publication platform, then they're published. Most recently, there was quite a storm over one paper that promoted ivermectin as a treatment for COVID-19. And that hit the press in a major way. So how can we involve patients in that process and get them to participate in evaluation of drugs, of papers that get published in the platforms? Because we now know that the press is taking those pre-publication platforms very seriously, and many of their stories actually come from papers that have yet to be peer-reviewed.
Yeah, especially in the case of COVID. Yeah, that's for all the 3 speakers, the question.
I'm happy to take it, although I realize I've answered the first 3 questions. I would say it's extremely difficult. I think education is key for the media, so they are aware that this has not been peer-reviewed. I think what at least my work is doing is getting patients involved in the peer review process. I think it's a new phenomenon, these preprint servers, and solutions have not been made yet. So at least my mountain is getting patients involved in the actual peer review process. But maybe David or Mabel have something else to say.
Hi, yes, just to echo that, I think it is new territory for us, although we've been learning exponentially in the last 2 years. I must say that the Lancet has also been involved in SSRM, which is a preprint server. And I know that a lot of, in the last 2 years, a lot of preprint servers have had to instigate some sort of vetting mechanism for what they put up there. It is no longer just sort of okay to put everything up there, but I suspect, capacity is limited, and even at the Lancet, although we now do have one of our senior editors vetting what goes up, it is difficult even to get that far. I think your comments are good ones, and might be something that we would need to consider as well, incorporating PPI. Might I also say, just very quickly, with reference to the previous question about, if Donald Trump wanted to put their hands up to review something, would that be a problem? And I must say, I'd echo Ciaran's comments that we've always found patient peer reviewers to be enormously engaged and to give incredibly constructive comments, but also that it's not just patient reviewers who might potentially be a bit off grid. you can get academics who might have some very unusual responses to articles. And, if there's any concern about that, the answer is always to get more than one reviewer with that expertise.
Yeah, I don't really have necessarily anything to add to either Ciaran's or Mabel's comments, but really, I think this whole area of the spread of potential misinformation is bigger than medicine. And I think there needs to be potentially something done about vetting that more carefully in the distribution of misinformation, particularly when there's harm associated with that. And we've, I guess, seen that much more prevalently during the context of COVID. I mean, the general public, I think their knowledge base has improved dramatically with the widespread use of, case numbers and testing rates and widespread use of vaccination numbers. But I still think there's a lot of misinformation that goes out there that misleads the public, that oftentimes causes harm as a consequence. Ivermectin is one example, and obviously the widespread prevalence of people who are purporting bad things that come from vaccines is another. But I don't necessarily have an answer. I just think it's something that we need to think very carefully about as a society.
Thank you. Sorry.
Just very quickly to say, I would certainly support Ciaran's previous comment about the media, and I've certainly noticed that most of the major media outlets are taking great care to make sure that they say where something is from a preprint server and not peer-reviewed, and therefore to be taken with caution. So I think that education is certainly key to this.
Thank you. I'm sorry there are two hands on, but we must follow because of time. So thank you very much, all of three. This is the end of the first roundtable of the third pre-congress of OAFI. And now we've make a very short break to let the introduction of the second roundtable. Thank you from Australia. Thank you for you, and see you soon. Bye.